those that are remoting in, we will take questions when we're done with these remarks, and we'll rotate between the people here and the people on chat. I also want to mention that Dr. Helen Chu will be available to answer questions about remdesivir following the report that we're giving today. Thank you for being here, and we're going to start with Dr. Helen Chu.
Thank you, Susan. So the Seattle Flu Study was a study that was set up approximately 2 years ago to understand the spread of respiratory viruses throughout a major metropolitan area. As part of this study, we developed a system for people to collect a swab at home and send it into the lab for testing for flu and other viruses. When the coronavirus pandemic started in January, and we realized that we had the ability to detect coronavirus as part of our Seattle Flu Study, and we rapidly pivoted to development of an assay led by Leah's lab to detect coronavirus in the samples that we had collected as part of the Seattle Flu Study. In this report that was published today, we found that of the several thousand samples that were collected from January to March, we found evidence of coronavirus in 25 of the samples. And these samples that tested positive started at the end of February. As you may have seen earlier, the first sample that we found that tested positive was provided evidence of community transmission of coronavirus in the United States. And that's it.
Okay.
We're going to move Mike.
That's good. Should I start? I'm Leah Starita. I am the co-director of the Bratman Beatty Advanced Technology Lab. And yes, I'm Leah Starita. I am the co-director of the Bratman Beatty Advanced Technology Lab. And while Helen was able to get, innovated in all the different ways to get the samples in terms of, this really cool swab and send program where our participants were swabbing their own noses at home. We were We developed high throughput methods in order to be able to test all of these samples for 27 different pathogens and also sequence them and sequence the viruses we were interested in to understand the transmission chains. As the news started to come out of China in January, we quickly decided that we needed to develop a coronavirus test for SARS-CoV-2. And we did that, and we were able to rapidly detect community transmission within the Seattle area.
Do you guys want to start with questions? Do you guys have a question here? Okay, Katie, do you have any questions on the chat? Not yet. Okay. Do you want to go into, what else do you want to mention about the study?
Sure.
Mike's back again, sorry. Why don't you show that, yeah, why don't you
Sorry, let me put on my mask. Here. Okay. So one of the advantages of this study is that it demonstrates the ability for people to collect a swab at home and send that swab in for testing for coronavirus. This can help in a variety of ways. First, it helps us find people in the community who may have coronavirus but may not be sick enough to come into the hospital or the clinic, but still could be sources of transmission. So if we're able to find these people early, tell them that they have coronavirus, then that would change their behavior and allow them to isolate at home and prevent transmission to others in the community. The other key advantage of this kind of approach is that people who are sick can stay home and test themselves at home without exposing others in clinics or hospitals to coronavirus. It saves us on masks, on gloves, and on gowns, all things that are currently in short supply. This is an example of a kit that we use for testing for coronavirus at home. We developed this in collaboration with a company called Formative, who helped us with the design. What happens is you go to our website, seattleflu.org, you click on a link, you answer questions, you consent to participate in the research, and you have this sent to your house, and it can arrive to your house within about 2 hours if you're here in Seattle. Then when the kit arrives, there's a card that tells you what to do, and it has very clear instructions inside about collecting the swab. You then go to the box here. This is the tube that you put the swab into, and this is the swab that you collect. What you do is you open up the swab, and then I'm not going to do it, but you stick it up to into your nose, up to the stopper, and then you twist it. Then you put it into the tube, you cap the tube, you go ahead and put it in this bag. You put it back in the box, and then you send it back to our lab, and it arrives back in the lab in 2 days. Then Leah's lab runs the test, and the result shows up on our website. And then if you're positive, you're called, and you're notified that you have coronavirus. And this is a novel way to think about expansion of testing, both here in the Seattle metropolitan area, and then as we shift towards more of a early detection and isolation strategy to allow us to reopen society, this will be key. This type of approach of being able to test at home without exposing others will be key for rapid scale-up of diagnostic testing.
So how will you get the results? Will you guys call us on the phone, email us, or?
We call you. We call you to tell you the results if you're positive. And then what we do is we then direct you to public health, and we give you instructions in terms of isolation at home.
Is there any worry about the accuracy of it? Someone doing it at home, swab with their nose, are they getting enough? Are they getting, you know what I mean? Is there any worry in that?
Yeah, that's a great question. The question is about accuracy of the test when you do it at home. So we're working on several studies now to do a direct comparison of this versus something that's collected by your doctor in the clinic. I can tell you that since we started this study, there have been a lot of studies that have been done, and FDA has approved a kit for home self-collection, and also approved collecting a swab in front of a provider in a clinic. So both of these things, having a kit sent to your house and then having the swab collected by yourself, are things that the FDA has approved. The work that we are doing is specifically to generate the data to provide to the FDA for this particular process to be used for home-based diagnosis of coronavirus.
How many kits do you have available?
Is it several thousand? So we have several thousand kits available.
Right, we're going about 400 a day.
Yes, so Leah's lab has the capacity to test up to 1,000 a day. We're currently receiving about 400 as part of our new surveillance platform called SCAN, which is being run under the direction of Public Health Seattle King County, where we took this research project and turned it into surveillance for public health.
And where do you get the kits from?
We make them.
When you say swab up to the stopper, can you elaborate on that a little bit?
Yeah, so the instructions are here. So what you do is you basically stick this up your nose, and then you get to the stopper, and then the key, as we instruct people, is to really scrape the side of your nose, because the virus lives in the cells, and if you're trying to scrape off the cells that are on the side of your nose that carry the virus.
So there's an actual stopper on the swab.
Yes, it's right here. Yeah. So it's a plastic stopper. This is the size that you use for adults. For children, it's a much smaller stopper, or a much smaller swab, and the stopper is much higher up because their noses are so much smaller.
Is there any surprising you found with this report? What are the key lessons
I think the main key lesson that we found was that we found early detection of coronavirus here in Seattle, and this first evidence of community transmission in the United States. We did not expect to find coronavirus so early. The other thing that's, I think, really important that we found was that the minority of people who tested positive ever presented for care. So that the people who were testing themselves at home did not ever go into a clinic or a hospital. So they either weren't that sick or just didn't come in. And I think what it means is that there's clear evidence of people in the community who have coronavirus who are either not sick enough to come in or just choosing not to come in, and then they're probably part of the transmission chains.
We've got a chat question now.
Yeah. Should we-
Ben asks, will these be available to business outside the Seattle area?
I can do it. So that you guys don't have to.
There has been so the question was about whether or not this would be available in other cities, and whether or not, I don't think we're going to do it. So whether or not this will be available in other cities, we right now don't have plans to go outside the greater Seattle, King County area. However, many other academic institutions and medical institutions have emailed us, and we have made every piece of information available, from our IRB to how to put the kits together to our testing methods. They are freely available. We will send it to anyone. And so we know, for example, that something very similar is about to pop up in California as well.
Talk a little bit about the process when it gets to your lab.
So when it gets to the lab, we have to take all of these boxes apart in biosafety containment areas. We do it in biosafety hoods for the protection of our team. Then we check each of these samples in, and they go through a process called RNA extraction. So we have to get the genomes of the virus out of the media that they're in. And then we just do a very standard detection assay called RT-PCR. This is something we do in the lab all the time, and we can do it, fairly quickly. And those results then, as Helen said, go through an automated system for the negatives, and the people who test positive are actually getting, a real phone call from a human, which is, I think, pretty nice.
We've got another chat question here.
This question is for Dr. Chu.
Mm-hmm.
Who should take the test if you, who should take the test if someone doesn't have any symptoms, but they were showing symptoms?
So the question is about who should get the test at the time of shortage. Should it be used only for people who are symptomatic or people who are asymptomatic as well? I think there's a nuance to the answer to that question. So we know that asymptomatic people, or people before they have evidence of symptoms, still carry virus and are able to transmit virus to others. We know that there are certain populations where you're at very high risk to carry the virus, and that's now been shown in places like nursing homes and then also in hospitals. And so I think in those populations, there is a clear role for asymptomatic testing, because you, as the healthcare worker in particular, may be at risk to carry the virus and to transmit it to somebody who's more vulnerable, like your patients in the hospital or the people who are living in the nursing home. We also want to answer some key questions about certain populations that could drive policy, including what is the role of viral transmission in children. And so children, even though they have symptoms, I think there's a clear value in being able to collect a swab from them and understand if they are carrying the virus and what their role is in transmission. So there are these key populations, healthcare workers and children, where I think asymptomatic testing is probably warranted. It's currently not approved, except in a research capacity, and we are doing it as part of Seattle Flu Study and a couple of other studies that are ongoing. For the vast majority of people, symptomatic testing is probably the right way to go. That you do need to have symptoms to be able to have to in especially in times of shortage. But the problem, of course, is that people tend to have high viral loads before or right at the beginning of their symptom onset. So before you feel very sick, you are still have high levels of virus in your nose and could transmit it to others. So for example, if you live in a household with somebody who's positive and you're not symptomatic, it's still probably a good idea for that person to think about getting tested, because that person is at high risk to acquire the virus and then to further transmit the virus.
I have another question for online. Last time I was on the scan website, there were no tests available. How many people have requested kits?
I think we've been ramping up capacity for the scan study over the last couple of weeks. We just started it just a few weeks ago on March 23rd, I believe, and so. As we've been ramping up, we now have capacity to send out hundreds of kits and also process them in Leah's lab. I think that one of the things about SCAN is that as we look at the early results, the populations that we do want to collect more samples from for the purposes of surveillance would be people who are living in South King County and then also in children.
I have another question for another here. Is there a risk that test results could be inaccurate when people do this at home instead of at a clinic?
That's certainly possible. The biggest risk would be not finding it because you don't stick the swab up in your nose high enough to be able to collect virus. There are ongoing studies and there have been published studies showing that self-collection works and is comparable to a swab that's collected by a clinician.
And then what children should be tested?
That's a great question. I don't know that we have a whole lot of data about children at all. So I think if you have a child, we would like to know whether your child could potentially carry the virus. Children don't seem to be getting that sick with coronavirus, but the big question is, if they're not that sick, then when do we reopen schools? So I think getting more data in children about, even if they're not sick, are they having high viral load? Are they potentially able to give it to others? Those are questions we want to answer. So I think getting more children to participate would be great.
Any other questions? Yeah, we have another question. So, after seeing the spread of coronavirus in our community, what do you think are the steps that need to happen before reopening?
So in order to reopen, we're going to need a strategy where we can test way more people than we're currently testing. We need to be able to have both expansion of testing through places like walk-through clinics or walk-up clinics or drive-through clinics, and also potentially expansion to this type of strategy where people can simply click on a button, have the test kit sent to their house. Only by expanding testing so that anyone can get it, can we get to a point where we'll be able to identify hotspots early and to stop transmission within the broader community.
Do we have any questions that could draw their own report about that over here? If Dr. Kelly, give us just some remarks about that study that we were one of the clinical trial sites. Can you elaborate on that?
Sure. So the University of Washington was one of the trial sites for the National Institutes of Health remdesivir trial. This was a multi-site study conducted across sites in the United States and globally to understand whether remdesivir given to people who were sick enough to be in the hospital and had evidence of pneumonia could benefit them and decrease mortality and decrease symptom duration. So this was a randomized clinical trial. It was a comparison of remdesivir against placebo. And what we found in the early analysis of the data, which was released yesterday and as part of a press release by Dr. Fauci, was that remdesivir was effective in decreasing symptom duration and also had a trend towards decreased mortality with the very early data. This is not fully analyzed data. We have to follow up the entire cohort of patients, but it does show that we have an antiviral that works, and that can be used for treatment of people with pneumonia due to coronavirus, and it will decrease their time to recovery by several days. So for us in infectious disease who see patients all the time now with coronavirus, this is in many ways a game changer, and that we can actually have something that works.
How does it make you feel as a practicing physician?
I think it makes all of us feel very hopeful that we are going to be able to offer something to our patients. A lot of these patients, as I'm sure all of you have seen in the news, have been very young, and it's very hard to see the randomness of coronavirus in the very young. You usually see this in the older adults, but to see 20-year-olds, 30-year-olds intubated in the ICU, and to now know that we have something we can treat them with, as well as the others as well, that gives us a lot of hope. And I think it gives us the sense that there are probably going to be other treatments down the line that will work, other drugs that are active against the virus, and then also potentially other things like monoclonal therapies that could be used in the future, that could be that could shorten duration of illness and then prevent death.
You want to comment on anything else
No.
before we wrap up? Oh, hang on,
Oop.
one question. Back to the at-home diagnostic testing, how many tests have you done? What percentage are positive? What percentage are asymptomatic?
Are we allowed to say that? This is county data here.
Oh, I think we talked about what happened with SCAN.
Yes.
Or with the Seattle Flu Study, which is the 25 out of, so it was,
Okay.
we had found 25 positives out of almost 3,000.
Mhm.
But about
Okay.
approximately 3,000. Thanks.
I know. So during the Seattle Flu Study, and from these swab and send kits, we had tested about 3,000 of them and found 25 positives, which is a fairly low rate, but this was the very beginning of the coronavirus transmission and epidemic in the Seattle area. Now that we are the Seattle Coronavirus Assessment Network through the Public Health Seattle King County, you can actually find those statistics on the Public Health King County website. So we release technical reports. We've done about 10,000 tests so far through Seattle Coronavirus Assessment Network, and those results are online, and we're finding about 1% positivity still.
I have one more question, and this is about remdesivir.
I got it.
We gotta move mics again. So it's asking about whether we are involved in the second arm of the study, adding the immune suppressant.
So the question is about whether or not we're involved in the second arm of the study, and we are not. We are not doing that. So. There are multiple other clinical trials that are ongoing at the University of Washington, including a study of hydroxychloroquine, and then another study of hydroxychloroquine and azithromycin. But for the purposes of the second phase, which is called Act 2, we are not participating in that.
Thank you, everybody, for joining, and in person and remote. We're going to end this now, and appreciate your participation. Thank you, Dr. Chu, and thank you, Dr. Starita.
Spelling of her name?
Yes. Starita.
What was that again?